pleased to have with us Dr. Sushil Kumar Meher, Head Health IT, AIIMS, who will be moderating this session. Sir, please join us on stage. Mr. Himanshu Rastogi, Chief Technology Officer, Medi Assist Healthcare Services Limited. Mr. Rastogi, please join us on stage. Mr. Arun Goyal, Chief Information Officer, Sir Ganga Ram Hospital. Welcome, sir. Please join us on stage. Mr. Rajiv Sikka, Chief Information Officer, Medanta Medicity. I request you to please join us on stage. And Mr. J P Dwivedi, Chief Information Officer, Rajiv Gandhi Cancer Institute and Research Center. Welcome, sir. I extend a very warm welcome to all the panelists here and request Dr. Sushil Kumar Meher to take the session forward. Over to you, sir.
Good afternoon, and I hope you have a nice lunch here. Yeah, after lunch you must be knowing it. Everybody feel lazy and drowsy. Anyway, we'll try our level best to do this session more interesting, more practical, and more it will touch your heart. Yeah. Anyway, we have a wonderful panelist, and Mr. Himanshu Rastogi, one of the, he's a CTO in Medi Assist Healthcare. Mr. Arun Goyal, he's from CIO, Ganga Ram Hospital. Mr. Rajiv Sikka, well-known person, CIO from Medanta. And Mr. J P Dwivedi, CIO from Rajiv Gandhi. I request all the panelists to introduce about them, more about them, what they are doing in their hospital, just a briefing about their introductions. Over to Himanshu.
Good afternoon. So unlike my other colleagues who have been on hospital side, we Medi Assist are a third-party administrators where we administer the benefits, the policies that a healthcare insurance policy that an individual or a corporate buys. We try to administer, try to figure it out what are the payability clauses. So that's about my organization. We started our journey close to 2013, wherein we did a lot of things on technology, and we had all the nuts and bolts and pieces so that putting that machinery into action was never a challenge. So that's about me. I have graduated 2001 from IIT Roorkee, and I have been with Medi Assist for the last 7 years. Thank you.
Thank you, Himanshu. This is Arun Goyal. I am CIO from Sir Ganga Ram Hospital. Sir Ganga Ram Hospital doesn't need any introduction. It is a multi-speciality hospital in the central Delhi, situated in Karol Bagh near Rajendra Nagar. And I am in healthcare technology for last 2 decades. I'm BITS Plani and I am Calcutta graduated. Rajiv.
My name is Rajiv Sikka and I'm part of Medanta IT. Medanta started roughly 13 years back with Gurgaon as flagship hospitals. But in last 6 years or so, we have now ventured into 4 other states. So 5 hospitals and 1 more coming up in Noida. Great journey and great learning experience. Prior to that, I have never been part of the healthcare industry. So been with them for roughly 7.5 years. First exposure to healthcare, learning, and to some extent, very justifiably, proud moment to be associated with a noble cause and still learning.
Good afternoon. Pleasure to be here. I am J P Dwivedi, CIO of Rajiv Gandhi Cancer Institute and Research Center. So our institute started journey of modernization in 2010. I joined them in 2011. Prior to that, I graduated from Motilal Nehru National Institute of Technology. That time it was called MNREC in 1988. And since then I have been working with several multinational companies. Came to healthcare in 2009 where we were trying to implement electronic health record in Max Healthcare through Dell. And then in 2011 I came here. So we have a long history and probably in course of the discussion those things will unravel. Thank you.
Thank you, everybody. Let me introduce myself a little bit. Last 30 years, I'm working in IT department in AIIMS, New Delhi. I have seen the journey, IT journey in the country, as well as in my institute. Once the IT has been implemented in AIIMS 1988, nobody understands what is computer. And at that time, the culture was as such, it is very difficult to convince to the users to use the computers. And that's why the system failed to accept the computerization within the institution. When we talk about anybody that AIIMS is doing for computerization and why for computerization, nobody understands. But right now things has been changed. But little bit journey what I'm talking about it. 1999, the government has started telemedicine facility in India, and they have given 4 institutions for telemedicine consultations through satellites. And that journey means this is one kind of transformation that virtual consultations can be done through telemedicine facilities. And there is one success story I'm talking about it. During the tsunami, 2001, I think so that is, we have set up a new natal ICU in Port Blair, giving the training from AIIMS New Delhi. And that is appreciated by the WHO. So that is the one of the success story what it is. But this telemedicine has not taken up because doctors, those who want to take the consultations to the patients, they are not ready because there is some attitudinal problems that why you'll take consultation from another doctor. That culture, it was there and it was not been successful. But doctor to the patient, it was not possible because that infrastructure is not available to the patients. But in 2007, I have made a study which is published in Royal Society of Medicine, London. That paper has been accepted and this is published and you can get in a public domain also. That why telemedicine has been not successful in India. What is the attitude and approach toward telemedicine of the doctors as well as the health workers. Because one thing which has come up, without physical visit, treatment cannot be done. With the same approach to the doctor as well as the patients. But some of the people, they are ready to take the consultation. If they do not have the money to come and take the remote consultations, or the patient is sick so much it is not possible to transport to the patient to the tertiary care. But this culture has been changed. It has transformed during the COVID time. Right now, doctors is saying also, patient is saying, is it required to come to the hospital? It is not possible that virtually, why you will not do it? If required, then I'll come. So this is the transition, you see it from 99 and today we are 2022. So definitely right now, the COVID has taught a lot. All the experienced CIO, they have faced a lot of issues. And I'm asking each CIOs, what is their journey during the pre-COVID and during the COVID and post-COVID, switching to the new normals of the services. I'm giving each panelist 3 to 4 minutes to talk about their experience. Okay, Himanshu.
Thank you. So I'll share some of the insights. So like as Medi Assist, we process close to 4,500 discharges on a daily basis. So we assist hospitals that these 4,500 discharges happen like with minimal human interaction, and that's why like reducing the TATs. We did a lot of things, but I'll tell you like what were the challenges when COVID hit us. The biggest challenge was for our workforce. We were predominantly a floor managed organization wherein the people were on the floor. So all of the sudden these people moved remote, they were working from home. The collaboration was one big challenge. We got a lot of tools. The tools purchasing was easier. but training them, getting them accustomed to new things was a big challenge. Good thing is our workforce is ready. They know how to work from any locations. And trust me, like I have people ranging from 21 going up to people who retire from our organization. So it was challenging, but another interesting thing was we had technology, but I think COVID just accelerated the adoption of it. So prior COVID itself, hospitals were exchanging data with MediAssist. 80% was online. So that number was pretty stable, and it has been stable for last 4-5 years. So COVID didn't make a material difference over there, but the insured, the person who was getting hospitalized, we saw like 5 times jump in that. So people were using technology to actually submit their claims, send it to MediAssist, and we were able to convince the payers that hard copies may not be required. And it was extremely difficult, so we capitalized on the opportunity and then ensured that whatever was set as a new norm just stayed over there. And trust me, like last 6 months have been blessing. No one has said like physical papers are required. And we are fighting hard to actually convince the industry that physical paper is not a proof of an original. You can get as many originals, it's just a print. So we are convincing, fighting hard, but the biggest challenge that I have in upcoming years is to holding on to the numbers. 4 times jump, but it should just stay over there.
Okay, it is a very interesting story because during the COVID times, the infrastructure is a issues, manpower is a issues, and the process has been changed again. To beat all these things, definitely it is a big challenge, and if it is more than 80% their success, definitely it is a good achievement what I feel it. But one thing I will tell you, when you are data capturing, do you follow any standards on it?
So unfortunately the industry doesn't have, and we have picked up bits and pieces. So like symptoms, there is no code, but for ailments there are codes. So we do discover from discharge summaries, configure what is called ICD-9 and then ICD-10. These are various levels, and that is something that is in our system. Procedures, the surgical procedures happening on a patient, that also gets coded. We are working towards like digitizing the bills, but there is no industry standard as of now, so we are just digitizing it. But these are 2 standards which we have been following, and we have just ensured that we stick to it.
Anyway, for this, I can give a suggestion to you. Right now, you are talking about ICD codes, International Code for Disease. This is only a disease, but what is the clinical procedures, all these things? Government of India already given the free certifications, and you can download it. That is Medicity. This is for the clinical codes. People should start working on it. For these implementations, the CDEC Pune, he is giving a free training to use Medicity in their clinical applications. Thank you. Next, Mr. Dwivedi. Next, Mr. Goyal.
Thank you, Dr. Mayor. So yes, I'll go to the first question of yours, the pre-COVID and post-COVID and during the COVID, how the digital transition happened and transformation happened. I would give credit to the COVID pandemic, the digital acceleration, I would say, and we have achieved, particularly in the healthcare arena, digital transformation in a big way, and we got a support from the clinicians and the patients to make it happen, and now we are into a second, the next level, I would say, of the digital journey, where people have adapted, clinicians have adapted, patients have adapted. And of course, we came up with a lot of process transformation during the COVID, wherein we came up with the touchless receipts, touchless prescriptions, and digital copies of the records into the hospital, which still we are following up. So that is something which got accelerated into the digital journey in the hospital. Furthermore, so far as telemedicine is concerned, which you mentioned about, yes, telemedicine is also got accelerated, and patients are adopting telemedicines. The options are available. We also integrated with our HIS, We have online appointment system. Patients are adopting online appointment system. Clinicians are comfortable giving consultation online, and so is the prescriptions. And we have integrated with the pharmacy so that the patients gets the pharmacy issued to the during the digital consultation at their doorstep. So that got accelerated, of course, and credit goes to the COVID pandemic. During that thing, everybody wanted touchless and remote access and services in the healthcare too. So far as within the hospital, yes, we did face a lot many challenges wherein we had to transform and change our normal beds and normal wards into the COVID wards, change into the normal wards, made lot many consumables into the free of charge issue to the patients as per the government policies. So those nitty-gritties we yes did face into the HIS, and those were the challenge during the pandemic. But now the things are normal, things are coming rapidly into the normal phase. But yes, I would give credit that telemedicine etc. has picked up and become a part of day-to-day routine as of now. And some good practices like e-prescription, e-pharmacy, etc., e-receipts have been adopted by the patients also, and so is the system.
Thank you. But as a CIO, what you are talking about the appointments, you have taken an appointment for a month or two, am I right? I'm not asking to you. You take the appointment for the patients for a month or two in advance appointment. Yeah.
It depends upon the slots available with the consultation consultants, because we allocate based upon the consultants' availability.
Okay,
so those are available on site.
So one person can take up to prior to 1 month or 2 months? Yeah.
Yes.
Why I'm asking these questions? On March 24th, it has declared that all are closed down. What will be the data appointments? And patients are critically ill, they have appointments, they have to show to the doctor. What CIO has to do it? They have to communicate to all the patients. This is the issues, this is the things it has to be do. You have to reschedule it. Who will be in the virtually has to come. So this process takes a lot of time to change ourselves. In my cases, it was like that. They had taken an appointment that on 25th of March, he has to do the chemotherapy, and it is closed. And if he will not do the chemotherapy, within 6 or 7 months, the cancer tumor has grown up. Who will be responsible for it? I have given an appointment to them. So these sort of things are there. Definitely the CIOs has a tough time at that time. That how to reschedule it, how to make different process to make it. So these are the challenges definitely you might have faced it during your time. Yeah.
Yeah, these type of many challenges, if we start enumerating those type of challenges, the list will be a long, because you have to make a refund process implement into the system. Refunds were having directly from the banks to the patients' accounts, which should have been visible onto the websites. Those type of technical glitches were there, but we had to live with it and made sure that these things gets addressed. And we did lot many workarounds and made sure that patients and the respective stakeholders gets informed the decisions there. And
yeah, and second thing is that again when it has, see, the first wave has come, again you have got open your hospitals, then second wave has come. So switching over is a big challenge.
Yeah, so these type of many in every department, every section, we used to face that type of challenges. We were there was a situation when we were giving remdesivir or the COVID injections to the other hospitals, and we were receiving from other hospitals. You need to make sure that all batches gets into the system, and then only gets issued when patients, and panic was all across the hospital, and you need to make sure that medicines are getting issued before it is getting into the system batch wise, and all those regulatory requirements are taken care of. So those type of many challenges, all CIOs would have gone through during the COVID phase,
time,
and we need to make sure that all the IT teams are making all these problems get over to provide the service to the patient.
One thing in my cases it has happened that I have to open 70 virtual consultation room in AIIMS. I need a video camera, sorry, VC cameras, and that is not open. Market is closed. So I made a phone, if somebody has opened the phones, then I have taken special permissions, and I have taken special permission to open the shop, then they have collected it. So these kind of things we have faced during that period of time, yeah. Over to Rajiv, what is your experience? Can you share with us?
Sure. In a hospital, there are multiple stakeholders. There are physicians, there are lab doctors, there are radiologists, there are nurses, there are technicians, and so on and so forth. And definitely, patient is at the core of each and everybody. I'll give, there are multiple examples for each of the stakeholders, but let me generalize it. There were three distinct waves which came in the COVID. First wave was nobody knew, suddenly there was a Janta curfew, then next day there was a 2-day curfew, and then there was a 15-day curfew. So, it was like suddenly coming on your face, nothing. So that first wave for a CIO was to make sure things are working, things are happening, whether it's work from home or somehow, getting things connected between multiple hospitals in our case. So this was phase 1 for us. So make sure, just do it. That is, my definition for a CIO for phase 1. Phase 2 or the wave 2 for us was that, whatever things were working and you were able to make it just happen, make them in the institutional form, which means that you cement it. You make sure that now this is part of your institute journey as far as those initiatives are concerned. So telemedicine is a very famous example, and I'll give more examples. Third was, when the third was, according to me, third wave, what we decided is that whatever initiative we took across hospitals, let's make them as part of the larger initiatives in form of a more structured approach to make it part of your 3-year, 5-year roadmap. So that's what we did. I'll give you one example out of many which we did. 2020, June, when suddenly Government of India decided that less symptomatic patient or asymptomatic patient can be treated from home. This notification came on a Saturday afternoon. We were sitting with district civil officers, and nobody knew, especially tertiary care hospital, which have seen patient only and only in the hospital, knew how to, treat a patient remotely. So nobody knew anything. Within 48 hours, Monday afternoon, we were ready with the portal by which we were enrolling patients. It was not a sexy app. In 2 days, you can't even write the specification for an app. And we were supposed to, make an app up and running, both with the portal as well as the patient app, by which patients were enrolling. Based on the enrollment, daily notification, and a simple form was there where they were adding their basic vitals and other stuff. And triaging was happening immediately there. Based on the vitals, if something is below the threshold or above the threshold, immediately notification goes to a nurse or a doctor, depending on the criticality or subjectivity, which we have defined as per our understanding of the protocol. And then everything went smoothly. No country, irrespective of Western countries or India, was in a position to handle those many patients because there were no beds. And only way we were able to support or manage the situation in the country was through digital. So whenever the scale comes, my natural instinct is that it has to be digital. Otherwise, it is not possible. So in this particular case, we treated tens and thousands of patients without they actually coming to the hospital. And that, June 2020 was a moment of fear. We all have seen that phase. So in that fear of moment, if somebody was there, somebody making a call, some nurse calling you on a daily basis, telling that, don't worry, you're okay. And when the enrollment or 21 days of isolation was over, there used to be a good report going back to the patient. These were your vitals. This was the treatment which was given to us. And obviously, we were sending phlebo twice in that 21 periods to take the basic blood vitals. So this was one experience, according to me, was a foundation for us for thinking about care away from the hospital. And we are now of the strong opinion that Medanta will definitely come out with multiple programs in which we'll be doing care away from the hospital. It was never thought about putting up an infrastructure of Medanta size and then thinking about care away from the hospital. So I think COVID has taught us that future of the care will be away from the hospital.
Yeah, it is a nice example. This COVID has taught us and given a road to us that this is the future of your healthcare. It is excellent work, definitely, and definitely I am so much happy that my friend Rajiv, they have implemented in their hospital. This is a wonderful job. Next to Mr. Dwivedi, what your experience, sir?
So our case is slightly different from Rajiv or Arun. They are multi-specialty hospitals. We are specific cancer hospital. But even here, if I categorize, different stakeholders, the impact of this COVID came in point of view of CIO first, my own assessment of what is digital transformation. What do I count as digital? Second is from the patient's point of view, and third is from the doctor's point of view. And it is very interesting. I was thinking that if I provide kiosks, if patient is able to do self-service, it is a fantastic digital transformation. I thought that cancer care is all about touch and feel. So doctor cannot do surgery, cannot administer chemotherapy, or cannot do radiation therapy from remote. So that means I need not worry about telemedicine. This was thinking, if we give kiosks, patient can see the reports, can see the pending bill, that is good enough. But that changed the perspective entirely when we saw that instead of 700 visits in OPD per day, we came down to 200. People needed care and they wanted to consult doctor desperately. There are symptoms. So we need to do some triage, who needs to be called immediately or who needs to be given treatment from home. So the need for telemedicine came, and that came as a matter of urgency. Now, as Rajiv said, we didn't have telemedicine app ready and we could not wait for that. So we had a very simple provision in our website to donate money to the hospital. We just created under variation, deposit money to hospital account. And then our accountant will reconcile that, okay, this was for OPD. And then give, the personal number, mobile number, and have a WhatsApp call or whatever video call was available. We had, fortunately, Cisco video conferencing. So we started using with that. And then we came out with our app, and that came within 1.5 months. And we made sure that app is not like any third-party app, because the integration is a nightmare. So we made app through the HIS partner so that a common database is there and it is always available. But that was my perspective. Patient's perspective, naturally patients were scared and they wanted a facility to consult doctor from home. So telemedicine became of paramount importance as we talked. Third was very interesting, doctor's point of view. Doctors were not happy adopting online, electronic health record no matter what we do, because our applications were not friendly enough. Too many clicks to the computer looking at the screen, that is not a favorite thing of the doctor. And doctor typically says, listen, patients come by my name, I write the prescription, I perform surgery. I mean, come on, who are you to tell me how to run my business? And now the situation changed. Doctor did not want to touch the paper because that paper might be carrying that virus from anywhere. And doctor is very happy writing electronic health record and typing things, and that immensely helped. So we consider COVID as CIO in chief, which we could not deliver. COVID delivered.
Yeah, thank you. It is a nice example. Similar case, it has happened to you. In the COVID ward in NCI Jhajjar, we have 750 beds. In that cases, earlier we have tried to implement capture the clinical system in your notepad, and nobody is agreed for it, because who will carry this one, who will be responsible for this notepad, because this is official. But during the COVID time, they have accepted it and they have started using it. This is the one thing what we have got from the cultural changes in this. But the main, during the COVID times, we have got an opportunity as well as the we have upgraded ourselves. Earlier, what we are talking about it, when we need something, we have to go to the top management, so we need this kind of budget is required. Right now, when we'll talk about the budget, they listen twice, really they needed it, then we have to give it. And they are making the provision for the budget. I think everybody will agree in this point, yeah. Uh, Next, my questions to my panelists, it is, what is your top priority or your roadmap for the next 5 years? If similar kinds of things it has happened again, so you can sustain easily. This is the one of the things we should know it. When we have not learned from the past, then what we have learned. So same things, if it is repeated and we are facing same problems, same challenges, if we coming similar kind of things again. So, so what kind of means provision you have made it? If it will come, same things it will come, or when you want to grow up after the COVID? Over to you.
Before I answer that question, I'll give you two perspectives which I thought are important. So in our organization, we have never seen tech as a cost-cutting measure. We have always seen it for it to solve a member experience. And small part of it could be like accuracy and consistency. So we use technology for solving member experience. And cost cutting happens as one of the key results. It's never an objective. That's number one. Number two, what I think, like in many other industries, consumption will happen very close to the consumer. Traditionally, the consumption happened like you had a shop, people used to walk into the shop and then buy it. But now, be it medicine, it's getting door delivered. Be it food, it is getting door delivered. So my priorities for that would be like, try to solve for member experience, usage of, like it's not fair for a consumer to jump from one channel to another channel. So like some of my colleagues were saying about doctors jumping from one screen to another screen, and that's pretty obvious. Like doctors will use laptops, desktop, they will turn to iPad, then they'll turn to phone. So we need to ensure that whosoever is our customer is seamlessly able to talk to us in any other format. Like if offline phone was there, email was there, bots should be like prevalent, and they will be like, should be able to ask, get immediate answers and seamlessly hand over to complex questions being answered by experts. So bots would take major step. Number two, on operational efficiency, like use of technology interventions, like they're dime a dozen. So keep on finding them. Like simple example we have used is an RPA, wherein I was able to get mundane tasks which humans need not actually apply intelligence. It was mundane, it was SOP, just get a bot in place and then it keeps on repeating itself. So these are two things which I think would be priorities for me in coming years.
Yeah, there's two things they have planned out. It is the bots and another one is the RPA. Definitely in healthcare, bots is one of the key tool for us, because many patients, they do not know where to move, who is the specialty, who's supposed to visit. In that cases, we can cut down their time and through bots and choose the right consultant for their treatments. Next, Mr. Goyal, please.
So next, you asked next 5 years roadmap. I would say next 1 year roadmap, which we have come up with many challenges during the COVID. Yes, of course, the roadmap is in line with the digital transformation which we recently came across. So we are venturing into holographic surgery in next one year. So project is already on. So that is also outcome of touchless pre-surgical preparedness in the hospital. That is one of the initiative which we are getting into it. Doctors and clinicians are coming up with the requirements that you need to come up with something EMR product where you can give us touchless or keyless input to the EMRs, wherein some good solutions can be available, and we whatever we would like to write, we can give instructions to the system, and system can convert it into the prescription with the one of the best AI available voice processed EMR solution. So yes, of course, he's smiling. So one of the partner is there.
Not a sponsored panelist.
So, yeah, so clinicians are desperately looking for something where, as one of the panelists mentioned, that they don't like to key in as much as less keys they can punch, or rather they prefer that if their voice or their prescription or consultation, whatever they are giving, the clinical terminology can get transformed into the digital form properly, obviously following the ICD and SNOMED CT standards, following up into the transition. So those are the initiatives which we are looking for. We have learned that during the COVID we came across something where because the data pressure was there, the processing pressure was there, so we need to have some proper disaster recovery system into the cloud, wherein we are coming up with a hybrid system, on-prem data center and on cloud disaster recovery as well. We are coming up with a more richer and more experiencing telemedicine solution, which will be enabling patients to take the appointment and consult with the doctors. Even doctors are not in the hospital, they can go into whenever doctors are on move even, they can have a consultation because clinician want it that way, and save the OPD timings during the teleconsultation. So those are the initiatives which are on roadmap on the digital transformation going forward.
Anyway, definitely 5 years is a very long way to go, and the majority of any IT infrastructure, the life is 5 years. So anyway, because technology is changing and transforming so fast, so it is very difficult to catch the technology. And today's days, technology is not an issue. To choose a technology for your own, that is the challenging for us, because you have a variety of solutions that is available in the market. Okay, Rajiv, what is your roadmap? Yeah.
Somebody asked me what is digital transformation. So digital is always a bouncer, transformation itself is a bouncer, and combined together is a major googly. I don't understand digital and transformation combined together. So for me, it's very, very simple. Whenever we take any project, we say that it has to meet one or following objectives. First is definitely clinical outcomes. Second, patient experience or service excellence. Third is on your cost optimization. Fourth is operational efficiency. And fifth is the revenue assurance. Revenue assurance, mind you, is different from revenue. It is activity being carried out and has to be built. And there are many, many gaps in a typical tertiary care hospital. So these are the 5 objectives which we have for most of the initiatives which we take in Medanta. Now coming back to what is the underlying theme in the digital transformation for next 3 to 5 years for Medanta, which we have recently presented to the board. One common theme, and that is coming from the learning of the COVID, that care will be away from the hospital. So which means that whenever something is away, remote, it means it's digital. So it will be digital. Third thing is that the experience of providing asymptomatic patient care, which were in tens and thousands, was that don't wait for perfection. Done is better than perfect. So make sure that you do it. Obviously, you will not compromise on the quality of the care, but don't wait for model to be perfect, because we don't have the luxury of the time in COVID, and also till date we have not been able to reach to the patient in outside the metro cities. The typical dream of the forefather, including Mahatma Gandhi, education and health. Both of them are in real mess because we have not been able to reach to the patients outside metros, and only way to reach is digital. So that's what is the underlying stream which we have, and I can give examples as we move forward.
Yeah, Mr. Dwivedi, yeah.
So Rajiv, playing a bit of moderators, you not only understand digital and transformation, you are champion of it.
Yeah,
We have
yeah,
seen it.
yeah.
Okay, so coming back, now I'm actually worried worried on two fronts. One is we have brought the doctors on board. So in our OPDs, 84% plus notes are now being put in real time online. 98% of our chemotherapy workflow is online. Only 2% new coming in. They take some time to come on board. Now problem is we have brought them on board for OPD. Now they are demanding that, facilitate OPD IP notes also. And one doctors, all patients are not there in one place. They are on the round at different locations. So they want to put in notes real time and quickly. So as Arun was telling, we need something like handwriting recognition or voice recognition. We have been experimenting, trying, not successful so far. Hopefully with friends like some present here, maybe we'll reach.
Yeah. It is
here.
already there. In the
No, it is not a match fixed, be assured. So, and second problem is actually bigger than that. And that problem is now, because we are going online, so this data, healthcare data is very precious and very prone to, it's very dear, more dear than money itself. So I need to protect the data and ensure availability, that when doctor is trying to key in something, the system doesn't go in round and round and round. Believe me, doctors don't have patience. And anyway, in India, they are very busy also. So performance and security are major areas, and here we are, my prime focus over next 2 years will be here.
Yeah. Data security is one of the main challenges today's days. Yeah. One example I am giving you, if we talk to a hacker that I want to have one bank statement of a particular person in US, they will charge you around $25 to $30. But if you ask for a medical record to be hacked of a particular person, they'll charge you around $40 to $45. So what is the demands you see it? So always health record is one of the most important, and that has to be secured. But yet it has not been matured because we do not have any government directions about the security of health records. That is the one thing. Because still in the morning, same question I have asked to the panel, that personal data protection bill has not been yet approved from the parliament. Anyway, this is my last question to everybody. When you are doing any transformations, there is a lot of people behind us. So how to carry these people along with us, update their knowledge, right people in right place, otherwise you can't do it. And in digital transformations, new technology coming up, knowledge has to be upgraded, and new peoples has to be come up. So this is the one challenge, in the healthcare industry. If you want that one specialized domain knowledge on healthcare and with technology, there are very limited people are there. So this is a question to my panelists, how they handle these things. Yeah.
So if you can just repeat.
In the one line I'm talking about it, the people, those who are working behind you, how their knowledge can be upgraded as per today technology, so that you can adapt the new technology easily for your digital transformations. That is my question here.
So what we've done is, in our business for sure, we've taken the decision making by humans and converted it into machine. So humans contribute to inputs, and that too only for complex cases. Whatever are simpler ones, machine itself can take a chance at it. So giving you a simple example, there are limited complication on a cataract, maternity, TKR, THR. These are package procedures and just happens, rarely complication happens. The difficult ones are medical management, so which I need to know what is the platelet count before I actually see that dengue case is perfect or not perfect. So what we have done is taken away that tribal knowledge which existed with humans and consolidated into machine, so that it is doing the same mistake all over again, so that you can correct at one place, you don't have to correct it with 10,000 people. So that is one thing that we have been bullish about it, and we have been pursuing it.
Thank you. Next, same question to you, Mr. Goyal. How to retain your manpower, those who are working behind you, and getting proper trained so that they can match as per your digital transformation requirement. Yeah, because technology is changing very fast, and manpower is a biggest issue. How you handle it? That is my question.
So Dr. Meher, answer to your question is in the capacity management with respect to the IT manpower management and the user trainings so far as the IT systems are concerned in the changing environment. So there has been a consistent effort with respect to the technology, whatsoever is getting changed, users are getting trained with respect to the technology, whatever is getting changed. But so far as the IT people or IT manpower is concerned, they are used to of working in the same environment. They need to just come up with a new product and new technology, new services. So far as the user or the stakeholders management or the capacity management is concerned, the respective trainings, respective manuals, seminars and training sessions have been done with respect to their day-to-day functioning, which is converted into the digital processes. And we need to make sure that they are following up the same process which they were doing in day-to-day routine. So it is, I see this as a IT responsibility wherein we need to translate, as my co-panelists were saying that we at times fails to transform the processes into the technology, then that is why we are not able to implement it. If we somehow we are able to transfer the processes as it is what users are doing into day-to-day routine, the technology adoption or the new things adoption doesn't become a challenge. So this is what is my priority generally, that whatever are the processes gets as it is transformed into the digital technology so that adoption becomes easier and the trainings doesn't come in as a challenge.
Yeah, yeah. Basically what it happens, when you train your own people, they have a lot of opportunity outside, they leave you and you will be again alone. So this is the problems we face it in regular basis, but still we have to run the show because we are the in charge of whole IT setup and business process in the organizations. Next to Rajiv, please.
Sure. So Dr. Sushil, on your last comment, what will happen if we have trained people and they leave? So counter is that if you have untrained people and if they stay in the company, this is a typical joke we all know. So now coming back to, this is more of an HR question. I'm fortunately as an IT guy, I'm blessed. I have to deal with machines. They follow my instructions. It's too difficult to deal human subject. But coming back to how do we train? And healthcare is not a classroom or a video-based training environment. Remember, Guru Dronacharya was for Pandavas and Kauravas, which means for the royal family. While we have too many Eklavyas in the country, so we need those many Guru Dronacharyas. Unfortunately, we don't have them. So what we need is that we need an equivalent mechanism by which real-time, simulated, augmented, training can be performed. You can't have a disaster, training in a classroom, which means that you have a trauma center, you have 30 beds, suddenly 50 patient comes, and you know the scene. In a hospital like Medanta, we daily see unruly people, times laptops are broken, window panes are broken. This is, I'm talking about Medanta in the heart of Delhi NCR. And this is not once in a rare case, almost happens. So this is the kind of situation, and just imagine, young nurses, maybe of my daughter age, 23, 24, they have to feed, so these kind of training can be done only by virtual reality or augmented reality. I'll give you a use case which is already implemented in Medanta. This is about a neurosurgeon. In a typical surgery, pre-case planning is very, very important. So what it does is that you have a 2D image, your CT and MRI are 2Ds, which means that radiologist and doctor is viewing, or surgeon is viewing your CT or MRI, which is a 2D image. Now he or she translate into a 3D, which is a skill, which is a function of a skill of a surgeon, which means the surgeon is trained, he will be in a position to simulate that in a 3D environment, and he will know that what to treat next day. So planning is done. But just imagine that this is a skill which is dependent on a human being, prone to error and definitely not scalable. Now, take it to the virtual reality. So you will have a headset, you will see the human brain, true human brain which has to be operated next day in a 3D environment, and 3 guys with a headset are looking into the brain in a 3D and figuring out what to do. So just imagine that the kind of anxiety which even a surgeon has, how well it will be taken care. And this is the training. Now other stuff is that same probably can be extended tomorrow for a patient education. A lot of times, God forbid, we have to be in front of a doctor. They will show you CT, angiography. They will show you, you see, this is a blockage 75%, 80%. Everybody is nodding their head as if they are getting, whether it's a 75% blockage, 2 veins are blocked or 1 is blocked. Nobody knows, but they just nod their head. So now translate into a 3D environment and figure it out how your heart is. So this is what future training will be carried out. I took an example of neurosurgery planning, which is already going on in Medanta. Whether it is fully adopted, answer is no, definitely no, because it will take some time for trust to come into the simulation model. But I am aware that my daughter is a medical student in a fourth year, and they get lot of training on a 3D virtual environment using augmented reality, and that's the future, and that's how the gap will be reduced, and we will have many Eklavayas getting trained in the country.
Yeah, thank you. What he has given the example of neurosurgeons. Can you give the training to a new surgeons in a life surgery? Nobody will agree it. That is just impossible. And this virtual reality and augmented reality, it can help them out to do it. We have one project which is running with the IIT Delhi and AIIMS. The project is funded by the ICMR, that how the virtual reality work for the trained to the surgeon for neurosurgery. It is led by the Dr. Ashish Suri from AIIMS New Delhi. Okay, next, this is the last comments from the Mr. Dwivedi. Please.
Yeah, I'll limit myself to IT staff being retained. And I'll be honest in admitting that I have never seen, at least in my 11 years journey as CIO, the kind of attrition that we are seeing in past 1 year after opening up. So this is a real challenge. We break the entire skill set into 2. One is core technical and other is techno-functional. Core technical, we are making hybrid teams with the suppliers. So big suppliers with muscle power and some core people in our team together form a combined team, and that really has broadly managed the effect of the attrition. Coming to techno-functional, we have done 2 things here. One is that change the role of different modules so that one person is able to support more than one module, and then created champions, IT champions within the user departments. So they are also able to play function of business analyst alongside our team, and that is pretty much helping us managing the situation. I guess now the alarm is ringing, so.
Right now, audience, definitely you must have learned about how challenges our CIOs are facing during the COVID and after COVID also. Can you?
So I think we've run out of time.
Okay,
We need to proceed with the next
so
session.
we are short of time. So if you want to interact with us on the floor, we can interact. And thanks for all the panelists. They have given their inside inputs to audience. I hope all the audience, you might have got some knowledge which we have experienced it, and we have converted to you. Thank you.
Thank you. Thank you to the esteemed panelists, and I'll request Dr. Ravi Gupta to please join us on stage and please felicitate our panelists here. Sir, if you could please honor Dr. Sushil Kumar Meher, Head Health IIT, AIIMS, who wonderfully moderated this session. Can we have a round of applause, please? Mr. Himanshu Rastogi, Chief Technology Officer, Medi Healthcare Services Limited. Thank you so much, sir, for joining us. Mr. Arun Goyal, Chief Information Officer at Ganga Ram Hospital. Thank you so much, sir. It was wonderful listening to you. Mr. Rajiv Sikka, Chief Information Officer, Medanta Medicity. Thank you so much, sir. It's a pleasure to having you with us. And Mr. J P Dwivedi, Chief Information Officer, Rajiv Gandhi Cancer Institute and Research Center. Thank you so much, Mr. Dwivedi. May I request the panelists to please have a group photograph with us along with the eHealth magazine. I think it's lying there in front of you. Thank you so much to all the esteemed panelists. Thank you so much for gracing this dais. Thank you.